the stairs, but all is good. I'm hoping that I have a couple therapists here that will be chiming in as well. So good to be here. I'm looking forward to this tonight, actually.
Thanks for being here. All right, how about Laura Myers?
Hi guys, I'm Laura Myers with Behavior Consultants. I'm the clinical director for our company and excited to be here as well.
Thank you.
Thanks for coming.
Carrie Kelly? Did I mess
You're
up?
close, Howard.
Oh,
I'm Carrie Howard, and I'm a CODA with Dr. Endocrinologist Excel Institute.
the infamous Carrie. It's good to
Ooh,
see you
I don't know about that.
virtually.
What's that?
It's good to meet you virtually. I have not met
Thank
you. I'm right across the street from you.
Oh, you are the Kyle.
Well, I don't know about the Kyle, but
He's-
Kyle.
he's the Kyle.
Thanks for being here. Oh, I see. Jennifer B. How about you? You there, Jennifer?
I am. My
There
name
you
is
go.
Jennifer Brown, and I am a speech language pathologist as well. And I recently joined Therapy Solutions just a short time ago. I retired from Shara ISD, and I flunked retirement big time because I wanted to work. And I wanted to come back to do what I used to do, which is neuro rehab. So thank you. I'm
Nice.
glad to be here.
How about Dana Earl? Oh, you're muted there, Dana.
Hi, Kyle, Steve.
There you go. No, you're okay.
Here and all that. Dana Earl from Director of Sales and Marketing from Advent Home Medical. I'm downstate, but we have a Petoskey office, and our Petoskey branch manager is also on. She can introduce herself, Jackie. She's been with us for a number of years, but just moved to that area. So I'll let her tell a little bit more about that. But I am, we specialize in home, high-tech home vents and high-tech respiratory. And I second the motion. Well, I will motion to the person drinking wine that when we can all get back together for this meeting, we all go out after and drink wine or whatever our drug of choice is.
All right.
Agreed.
Celebrate, yeah. Okay.
So Jackie, you want to introduce yourself since Dana kind of just did, but
Well, first of all, I can't figure out how to mute my phone, so
hey, that's okay.
if you can't hear me, that's all you're going to hear. As Dana said, I have been with Advent for a couple of years, and I just recently was promoted to the Petoskey branch manager, and so my husband and I just moved up here to Elmira, and we're loving this though. We're loving this.
Well, welcome aboard.
Well, thank you. I'm very excited to be here.
All right, let's go with Miss Kelly Green.
Hey guys,
I missed
so
you.
nice to see everybody. It's been forever.
I know.
And Kyle, you are the one and only. I have to say
it's
that.
not.
So I'm Kelly Green. I'm a neuropsychologist, and I work for the VA. And that's about it.
Well, we're very
all I'm doing.
here because I missed that face right there. So
I miss you guys too.
all right, we're gonna kick it to the LBBRG crew here. How about Anna?
Hi, I'm Anna Semmelbauer. I'm a physical therapist at Life Beyond Barriers. And that's about it, right, Kyle?
Rocking out the PT world there.
Woohoo!
Let's see. Haley, are you available?
I am available. I just turned it off because I was eating, so I apologize. Hello, everyone. I'm an occupational therapist at Life Beyond Barriers, and the one and only Kyle will give any more important details associated with us. So nice to see everybody.
Thanks for joining us.
You're welcome.
Hey, Megan, are you there?
I am.
Yay.
Woo.
Megan Malgren. I'm a physical therapist at Life Beyond Barriers Rehab Group, and that's about it.
I'm glad you're here.
Thank you.
All right, Ashley, and I can only see part of your last name here, but it starts.
Would that be
with a G.
Lewandowski?
Okay, we have a couple Ashleys. Okay,
there's a couple.
Yes.
No,
How about go ahead, Ashley?
You're on.
All right, hey guys, Ashley Lewandowski, speech pathologist here. You get my 6-year-old photo because I'm multitasking currently. I work for Advanced Therapy Group. Nothing new on our end other than our OT, speech pathology, and our massage therapist, Rena from Rebalance, have been doing an uptick in home health care because no one's wanting to leave their home. So that's been great that we've been able to provide that. Keep us in mind if you have some clientele that cannot leave their space.
Great. How about Alan Bird?
Hey, I'm Alan Bird. I work for CRC along with Steve. Do a lot of the hardware, software setup.
Hey, Alan. Welcome aboard.
Thanks.
And Devin Burke.
Can you see me? Okay, good. Hi. Hi, I'm Devin Burke. I am the speech pathologist at Munson Outpatient Rehab at Foster Family Community Health Center. Something exciting that we have hit the ground running with is getting therapy into the Cowell Cancer Center. So now we have PT, OT, and speech over there. And one more comment, Dr. Noss, I hear you on the wine tonight.
Thanks for joining us. Jennifer Romberger.
Hello, I'm Jen Romberger. I'm a program manager for Neurorestorative.
Awesome. How about Amanda Pinto?
I am a occupational therapist and case manager with OCS, and I am also multitasking, which is why I'm not on video.
Thanks for joining.
You're welcome.
How about Emily Wolf?
Hi, I'm a physical therapist at the Lighthouse and excited to be here with you guys tonight.
Thanks for
Cool.
coming.
Welcome.
And all we have is Danielle. No last name.
Last name is Dugid.
I was hoping it was you.
I'm a life skills trainer at Neurorestorative. Good to see you, Kyle.
Glad you're here.
Thank you.
How about Ryan Campbell?
Hey there, guys. Can you hear me?
Yes, we can.
Okay, just making sure. I'm on the road driving back from Mackinac City, but Ryan Campbell, RN with AdvisaCare. I'm helping to oversee our new home health and hospice programs out of Charlevoix, and still overseeing the Traverse City private duty location as well. So good to see you guys all again, and I too am looking forward to being able to get this meeting back in person here soon.
Absolutely. Thanks for joining.
Yeah.
How about Douglas Van Dyke?
Hi, Douglas. Want to tell us a little bit about yourself? Yeah.
Okay.
Well, we'll move on.
All right. How about the other Ashley, Ashley H?
Good evening. I'm Ashley Henneman. I work with Ryan Campbell from AdvisaCare. My first time to the meeting, and shout out to Roxanne for inviting me, even though she's not here. And I couldn't be more happy to join the team and listen to what's going on.
Great. Thanks for joining. How about the infamous Marcia Tavelde? Marcia, you there? Oh, there you are.
I am.
How you doing?
I'm doing. So good to see you.
You too.
They don't let me out of the UP much anymore, you know.
Would you like to tell us a little bit about yourself?
I am a Marcia Tavelde, and I am a case manager with OCS. I serve Northern Michigan and the Upper Peninsula.
Well, hopefully you can get to leave the UP soon and come on down to lower northern Michigan.
All the trolls.
That's right.
That would be lovely. That would be lovely.
All right, I'm going to put our wonderfully amazing occupational therapy student, Grace Cooper, on the spot for a second.
Hello.
Welcome.
I am Grace. I am an OT student. Thank you, at LVB.
I'm
and
glad you're joining.
Excited to be here. Thanks.
And I think, did I forget anybody? Sorry, the list keeps growing here. We just have 2 phone numbers on here, and some of them might be connected to
Andrea Dubini.
Oh, there's that one.
I'm the relations specialist for Life Beyond Barriers Rehabilitation Group. Hi, everyone.
Hi.
Thanks, Andrea.
And then the other one, 2765 or 2821.
That might just be connected to somebody.
Oh, maybe.
All right. Anybody else that we forgot that would like to speak up and say anything? Speak now or forever hold your peace. All right. I think we're good. So just a few more items of housekeeping here. Just wanted to let everybody know that we still are going forward right now with the fall symposium, and that date is going to be October 22nd of this year. We're planning right now on a behavioral management, mental health aspect to everything, and we are looking at expanding some of our speakers to outside the Northern Michigan area. So if anybody has any ideas of any physicians or reputable speakers that you'd like to see, please let us know. Don't be afraid to shoot us an email, one of us on the board, because we would love some suggestions and some assistance if you have anything to offer with that. Also, we are looking for a new secretary. So if anyone is interested, please reach out as well. Basically responsibilities with that, we have a job description written up for that, but it would be attending monthly meetings and recording the minutes and keeping track of everything, keeping us organized, and being there to support for the quarterly meetings. So,
and also the conference and the committees.
Yes, the committees as well. So if anyone's interested or has someone in mind, please speak up and let us know with that as well. And speaking of the committees, we are also looking for individuals to join our outreach and our education committees. So again, if you're interested, please let us know. We also like to give everybody a reminder about our grant that we offer. The application is on the website, and we'll continue to give everyone a reminder at every quarterly meeting because this is a new thing that we are offering through the Brain Injury Network. But there is a certain fund of money set aside that we would like to be able to help out individuals, clients who are in need of maybe some assistance for additional bracing, some potential adaptive equipment, anything like that that maybe they just can't afford. So there is a process to that is all listed out on the website, and just want to remind everybody that that is available for use. We haven't had anyone take advantage of that yet, and so we would really love it if we start seeing some of those applications come in. Other than that, I'd like to have Steve give a membership update.
Hi, I'm the treasurer, and we have 6 single members and 21 corporate members. If you're not on the website, you are not a member. Your name might not be on there, but your company would be. And memberships are due in July, so I'll be sending out reminders in July to renew your membership.
All right.
I'm gonna talk to Cindy and Julie.
Yeah, hey, both Julie and Cindy, we just did introductions. If you would like to hop on, let's go with Cindy first. If you'd like to hop on and just give an introduction of who you are, what company you work for, and if you have any announcements. Oh, are you there, Cindy? Oh, maybe not.
Hello?
There you are.
Hi, I'm Cindy Pricer. I'm working with Paradigm. I'm the district manager for our Michigan team.
Awesome. Thanks for being with us.
Thanks for the invitation.
And is there a Julie Cook in the house? You have to unmute yourself, Julie.
This is why Kyle is my favorite coworker, because he helps me with this. Hello, good evening, everyone. I'm Julie Cook, and I work at Life Beyond Barriers Rehabilitation Group. And yeah, I'm happy to be here tonight.
Thanks for joining us.
Thanks.
All right, Sandy, would you like to give an...
I don't think we got Dr. Cole.
Oh, yeah, we don't have Dr. Cole on the call yet, actually. Dr. Cole, are you here?
I was just going to ask if he's joined us yet. Did
No,
you?
I don't see him.
7?
He has not requested to join. All right, we'll give it a second to see if we can track him. Oh, here he is.
Dr. Cole?
Still
Hey, Dr.
connecting.
Cole.
Looks like it's still connecting.
We're getting there.
Dr. Cole, you there?
Yeah, I'm here. You guys see me?
Not yet.
You may have to hit the little start video button in the bottom.
There we go.
There we go.
You guys see me now?
We can
Beautiful.
see you. Thanks for joining
Cool,
us.
right
Perfect
on.
timing. We were just getting to your introduction.
So
Yeah.
you didn't make your
Oh,
introduction.
cool.
That's a good thing.
Cool. I'm trying to think of the sharing the screen thing. Whatever.
We'll let Sandy introduce you quick, and then we'll have you share your screen if that's cool.
Sounds great.
Awesome.
Let me get.
All right, Sandy, you're up.
Okay, for those of you who don't know Dr. Cole, he's a physiatrist. He specializes in neuro rehab and head injury. He has bachelor's degrees in biology and religion from St. Olaf College in Minnesota, master's degree in exercise science from Ball State University in Indiana. He did his medical internship in Kalamazoo through MSU, and he completed medical degree and residency at the University of Utah in Salt Lake City. He came to us here in Traverse City in 2017 after a stint in Montana, and he is now the medical director for neuro restorative in Traverse City, as well as having a private PM&R practice at Kalkaska Medical Associates. And we are so glad to have him here tonight to speak with us. Welcome, Dr. Cole.
Thank you, guys. I'm happy to be here. So this is my first presentation on via the virtual format here, so I'll do my best, but we'll go ahead. Let me, as Sandy said, I'm a physiatrist. I did a lot of my training at the University of Utah. While there, I really learned that I love neuro rehab, and in particular, I love brain injury. I love the process of being able to be there when people were kind of at their low and help coach them through things and create work on creating quality of life with a good team. So that's one of the reasons I picked the field for physical medicine rehab. And so I'm really happy to talk about concussion management and brain injury, and then answer some questions afterwards. So I'm going to try to share my screen here and see if we can do this. Hold on one second. So share screen. Share. Oh, there's a lot of screens to share. There we go.
There you go.
From the beginning. Can you guys
Beautiful.
view slide? Let's try to, give me 1 second. I'm gonna try to, from beginning. There we go. Can you guys see stuff?
Yep, it looks good.
We're good.
You're good? Awesome. Thank you guys. So, yeah, without further ado, we will kind of get started here. So today I'd like to talk about a couple things. The first is diagnosing brain injury. There's a lot of misconceptions out there, and there's a lot of criteria that even professionals don't necessarily agree on, and it can make understanding brain injury difficult, and sometimes make the treatment of it difficult as well. And talk a little about grading the head injury, mild, moderate, severe. Again, there's different grading systems. A little bit about diffuse axonal injury, because with a lot of the patients that we see, particularly those that are in motor vehicle accidents or snowmobile accidents, there's an element of shearing occurring from the force. I mean, very rarely do you get a front to back type collision. It's normally there's twists and there's turns and different things which can create this diffuse axonal injury. And we're going to take a look at a little bit of the imaging, and then talk a little bit about post-traumatic amnesia as a predictor for outcome. And then we're going to talk about post-brain injury disorders and treatment. So what this entails is understanding some of the cognitive deficits and how we can use therapies and other modalities to try to improve people and improve the outcome. Talk a little bit about spasticity management and what spasticity is. Talk a little bit about chronic pain from brain injury, because unfortunately, a lot of people do suffer from chronic pain, and there are different ways to treat it, and there's a lot of different options out there depending on how the pain is presenting. So without further ado, diagnosing brain injury. So when we talk about brain injury and concussion, we often hear this term concussion. Oh, I just had a concussion. Well, folks, a concussion is a traumatic brain injury. I'm going to say it again. It is a traumatic brain injury. It used to be called a mild traumatic brain injury, and then people realized that mild really didn't state and give the whole picture. The concussions make up the vast majority of the brain injuries in the US. This data is a little bit older, but again, 80 to 90% of the cases, or about 2 to 3 million a year are reported. The majority of concussions do not result in the loss of consciousness. And this is where a lot of people don't understand that, even professionals. They think, oh, well, you didn't lose consciousness, so therefore you didn't have a concussion. And that is not true. So physical symptoms often resolve before the cognitive symptoms. Hence the reason that we have, therapies heavily involved, because some people will have issues, and we kind of refer to that as the walking wounded. They look fine and they look as if they're doing everything fine, but things aren't just working quite as they were pre-accident. So what is a concussion? So I have this little acronym. Any loss of consciousness, yes, blackout or seeing stars counts. Any alteration in mental status at the time of the injury. Any loss of memory for events immediately before or after the injury. And any focal neurologic deficits, either ones that are there for a little bit or last a while. Now, this is a little more of a broad definition, but it's been presented and has kind of taken ground, because we realize that concussions and brain injuries come in so many different forms depending on what's damaged, and kind of the mechanism, and even how the health of the person beforehand. So I use the acronym BAM to help me remember, and BAM with an N. And so a disruption of any one of these 4 features and an appropriate history or mechanism is diagnostic for concussion or mild traumatic brain injury. So I'm going to repeat that again. A disruption of any one of these four, again, blackout, alteration in mental status, memory, neurologic deficits, is diagnostic for concussion or traumatic brain injury. So there's multiple terms out there. Specialists don't agree on a unified grading system. That can be problematic for patients, because a patient may go to someone and say, you know, I'm having these symptoms, and say, oh, well, you didn't lose consciousness, you didn't have a brain injury. And they may go to someone else and say, oh, you absolutely did. You know, this is how we need to treat it. So it's frustrating for patients. The severity of injury is not always associated with the severity of symptoms. A classic of this is persons with what we grade as mild traumatic brain injury are more likely to have depression than those with moderate or severe brain injury. The reason for this is that oftentimes the people with mild traumatic brain injury do have a realization that they're not the way they used to be, and this can kind of create depression, whereas some of those individuals that are more affected may not realize that, and so they may not get those feelings of loss that someone with a mild injury gets. Most symptoms with concussion do resolve 1 to 3 months. That said, they can linger on longer. And then there's this idea of the second hit syndrome. Initially, it was everyone was saying, "Oh yeah, absolutely. This is what it is. If you get hit and you haven't recovered from the first injury, then your injury is going to be worse." Well, since then, we've realized that's not always true. But the general consensus is that if you do get re-injured and you aren't, you know, kind of recovered, or you haven't plateaued at a point, that you can be more affected. And I mean, that kind of makes sense, right? If you strain a muscle and then you go out there and do the same thing and you're not healed, you can hurt yourself worse. So that makes sense. So what is the anatomy of a concussion? So this is going to show with a, you know, the classic football kind of injury. So you up here for number 1, you have the initial impact. And then this is the coup injury, where the hit occurs. You also have the contra coup injury, which is the opposite side. So think of a pickle in a jar, and if you shake that pickle, the pickle will hit the front of the jar and then bounce towards the back. So that's kind of what the brain does. It's in that same sort of medium. And then if you get any sort of twist to it, if you shake it and don't shake it just right, you shake it with a little bit of a curve on it, what happens is this twist occurs and that pickle can kind of do a turn in the jar. Now imagine that pickle is suspended by some strings from the top of the lid. What'll happen is when that turn occurs, you get the strings break. And this is what we call diffuse axonal injury, or shearing. And I'll talk a little bit more about that, but that can be the difficult point of understanding brain injury, because sometimes individuals that have an otherwise normal CT can be in a coma initially, and it can because of this diffuse axonal injury. And then in very severe injuries, if we do not have if someone doesn't have surgery to do a craniotomy or open up, you can get increased swelling on the brain, which is called hydrocephalus, and you can get a brainstem herniation, which is difficult. So, and that's all sort of badness. So we don't want that to happen. So the old way of thinking was this. Okay, initial impact, you get the brain striking the inner surface, it rebounces back, the brain may twist, it swells. Okay, now get back in the game, or get back on the horse that chucked you. That's not the way we do it anymore. We've learned that there's actually an art to treatment for concussion. It's a delicate balance, because we don't want to get someone back too early when they're having the ill effects of the injury and where things have a tendency to ramp up and get worse. But we also don't want to keep them out so long that they become depressed and they get detached from the people they love and the things they love. So it's really kind of different. The pendulum has swung back and forth, and since then we've kind of realized that, okay, you know, the first 72 hours really kind of just not doing a lot, kind of the brain rest, low stim is really what we want. And then after that, a lot of times individuals have said, start to do a little bit more of an active recovery. And if you don't get symptoms in the process, you can continue to kind of do that. If you do get symptoms, then we're doing too much. So that's kind of the way the pendulum has swung more recently. One of the ways that we talk initially when someone is injured in an accident, we use this thing called the Glasgow Coma Scale. Again, it's just based on how the person looks and acts and interacts with us. We use it based on eye responses. You know, are they spontaneous? Are they blinking, looking around on their own? Their verbal response, are they oriented? Can they answer questions? Or is what they're saying not comprehensible? And then their motor responses, do they do what we ask? Do they withdraw from pain? That sort of thing. So I've got this little acronym on the bottom here that you guys can use for the ones that are practitioners if you ever need to use this. But 4 eyes, it helps remember that there's 4 there. Jackson 5, again, they were a music group, the verbal. So that's the verbal response. And then motor is 6. So that's the 1 to 6 there. So because that's the most important. Now it's not really, but that's the acronym I use to help me remember that. And so a lot of times you'll get this picture of a person when you're reading their history and physical, and it'll say, you know, initially presented period, they would withdraw from pain, but had, you know, weren't speaking appropriately. They were responding to, you know, basically verbal command, but it wasn't appropriate. And so you can go from that, and then you can create these numbers and kind of use the numbers to help grade mild, moderate, and severe. In general, for that, they've said that mild is basically 15 or more, moderate is like 8 to 15, and then severe is less than 8. So this diffuse axonal injury, again, if you look at the brain here, I don't know if you guys can see my cursor, but there's this white matter and then there's this gray matter. It looks kind of brown here. They have 2 different densities to them. And what happens when you get an injury that's got a trauma involved, if you get that twist, those neurons can break, just like that pickle that's attached in the jar, and that can cause this microscopic hemorrhages or small little blood, you know, products that will show up there sometimes on MRI, and it can create this swelling. And so that's kind of what we would see. It typically occurs not necessarily at the time of the accident, but a lot of the damage occurs within the first, you know, 3 days. And so that's why a lot of times individuals after a major accident will sometimes be put in an induced coma. They may have a craniotomy where they have their skull removed so that the swelling, as it swells, it doesn't compress any major brain structures and things like that. So we're just going to show a couple things on imaging. So again, diffuse axonal injury is characterized by multiple pinpoint areas on MRI, and it's normally at that gray white matter junction. CT will often show nothing. And I talked about a little bit what those look like, the hemorrhagic lesions. So here is what a grade 1 looks like. You can see the little red circles there. On an MRI, what it'll do is you'll see these little open black dots that can kind of be scattered around. Depending on where they're scattered is kind of based on the grading system that we use. In general, people with a higher number, so grade 3, are more affected and oftentimes have a harder time for recovering. So this is just kind of one view of the of what a grade 1 looks like. So the grade 2 is more in the it's the corpus callosum, so it's the brain structure that helps divide the 2 halves of the brain, and in addition to the stage 1 areas. And so this is a picture of that. And then grade 3 involves the brainstem. And as we know, the brainstem is the seat of our life. It's in charge of our breathing and a lot of other areas. And so this is why when this is affected, it can be you know, problematic for patients and prolonged recovery. So despite all of this, all this fancy imaging that we have and all this other stuff, imaging is not the best predictor of future function. I'm going to say that again because it's an important point. What your brain looks like on an MRI does not predict how you will do, which is good. So what is the predictor? So providers have done a lot of different things in terms of trying to figure out, okay, what can we use to predict? And there's something called post-traumatic amnesia that really we can do by asking questions to people. We found that this is actually one of the best predictors for how someone will do in the long run. This, what you see here, is called the O-log, or the orientation log. It's very simple questions. And when you get greater than 25 points, so that the scoring system is 0 for incorrect, 1 for correct with multiple choice, 2 for correct with logical cueing, and 3 for correct spontaneously, you end up, if you're greater than 25 times 2 consecutive days, then you're out of post-traumatic amnesia. And that's the length of time that you're in post-traumatic amnesia actually correlates fairly well to mild, moderate, or severe injury. Another one that is used is called the GOAT, the Galveston Orientation Amnesia Test. Some of the questions that are asked: when were you admitted to the hospital? Where are you now? What is the first event you can remember after the injury? Can you describe the last event that you can recall before the accident? What is your name? And again, this is a little bit more of a comprehensive one. So there's a scoring system of 100, and it's greater than 75 over 100 times 2 days means you're out of post-traumatic amnesia. So those are two of the predictors. So when we look at post-traumatic amnesia and duration of it, so less than 60 minutes, we often, using this, they'll say mild. If it lasts 24 hours, you're already into the moderate category. If it's 1 to 7 days, you're already in the severe category. 1 to 4 weeks, you're very severe. And then greater than 4 weeks is extremely severe. This is kind of what they had come up with. And the take-home point is the longer it takes someone to kind of come to and get their bearings, the higher likelihood it's going to be a more prolonged recovery. So again, this also shows a similar thing, classification of post-traumatic amnesia. It's a different scale, but it kind of, I guess, same scale, but it tells about what you can expect. So if the length of post-traumatic amnesia is less than a week, full recovery for most is possible with good management. If you get longer than a week, recovery can be many months. Most will have some residual problems. If we're looking at 2 to 4 weeks, process of recovery is very long, typically a year or longer, and permanent deficits are likely. And then greater than a month, permanent deficits and significant disability is likely. So that's kind of the way, I mean, we look at stuff and try to figure it out. The reality is it's not that simple. So when we look at traumatic brain injury recovery stages, so typically individuals, when they're recovering from a brain injury, will go through multiple stages. We've rated them from like 1 to 8, and I've got a little hint on the bottom for people helping to remember them, but it goes from basically not responding to having a generalized response to having a localized response. The idea would be as if I pinch somebody and they slap at my hand, that's a localized response to stimulation. To confused and agitated, meaning they're not necessarily appropriate, but they're getting frustrated and may not be directed at one person in particular. Confused with inappropriate, so that would be like, basically they're confused in the sense that maybe their dates are off, their time's off, and maybe they're saying some stuff that they shouldn't say. And then there's confused but appropriate. Okay, the person that, when you correct them, is, oh, geez, I didn't mean to say that, I'm sorry. And they're able to kind of keep a check on it. Whereas that person that's in the stage 5, where they're confused and inappropriate, they keep saying that kind of stuff. And then the interesting part about brain injury is that individuals who have an injury don't always start at 1. Sometimes they start at 3, sometimes they start at 4. But in general, the process of recovery is this stepwise recovery. Sometimes it takes days, sometimes it takes weeks, and sometimes it takes years. So this is kind of the path of recovery that has been used most commonly in medicine. So, and the purposeful appropriate is the last one. So does anyone have any brief questions kind of about the diagnosis of brain injury? I'm happy to entertain some questions now, and then I'll go through the second part, and then we can have questions at the end.
I do.
Okay.
Dr. Go. Okay. I saw on a neuropsych report recently that said that the client had a post-concussive syndrome, but I was surprised by that diagnosis because MRI showed definite bleeds in the brain, and I didn't equate that with post-concussive syndrome. To me, that was a clear traumatic brain injury. So is that typical? I've recently come back to TBI rehab, so maybe there's some new changes, and I just was surprised to see that in a report.
Yeah, so that's a great question. So post-concussive syndrome is by diagnosis symptoms from concussion or brain injury that are lasting longer than 3 months. So whether it's a severe brain injury or whether it's a mild traumatic brain injury, you can have post-concussive syndrome. So it just means that it's lasted longer than 3 months.
Wow, even with a bleed.
Yep. So yep, you can, and it doesn't matter whether it's, you're talking about a hemorrhagic event, meaning, there's blood in the brain, or whether it's an ischemic event. So if you're having those symptoms, it may have been different, 10, 15 years ago, but it's kind of evolved to the realization that a lot of these symptoms are related to this concussion, to the brain injury. So that's kind of the way that we view it now. So.
Okay. Thank
Cool.
you.
Any other questions? Yeah.
I have one.
Okay.
So.
Hey, Dr. Noss.
How are you?
Doing well. Good to see you.
I really like, obviously you cannot really use imaging to determine that injury. And I like the idea of some type of questionnaire, but are there any checks on malingering? Because that's always a concern.
Yeah, that's a very good point. I didn't address that in the lecture today, but the secondary gain is very real, but trying to figure out when is secondary gain and when there's persistent, lingering deficits. What I found is that's when a neuropsych is really helpful, because they put people through so many tests that it's really hard to fake it that long and to do it. And it can really show. And so what you'll see in someone who's had a malingering, it'll show kind of, they've got some questions that are basically what like trial questions that people with that are maybe trying to show a secondary gain will go ahead and answer abnormally that really should be normal. So that's where I really rely a lot on neuropsych in that regard. That's my best response.
Yeah, and that makes a lot of sense. I mean, because eventually we'll get that figured out, right?
Yeah. So, and all the time, and sometimes the problem is even if it starts out with secondary gain, if we tell ourselves something so much, we eventually believe it, right? So sometimes that can occur. And so it sometimes takes some counseling, not just the neuropsych, to help someone realize that some of the deficits that you're still having are deficits that, could be overcome if we are able to get our mind in the right frame of mind. So, it's not always the case that way, but there are, as you said, there are cases where people might have secondary gain. So, any other questions?
Hey, Dr. Cole, it's Kelly Green.
Hey, Kelly.
Hi. One thought that I have I'm working at the VA now. So the traumatic brain injuries that I'm dealing with are 10 years old, 20, 30 years old. And one of the difficulty that I run to, but even when I was working in the private sector, is after somebody's had a traumatic brain injury or it was occurred several years ago, sometimes we don't have medical records and we're exclusively going on the patient self-report. And we know that our memory for things that happen aren't very good. So that gets really tricky when we're trying to assess severity of traumatic brain injury, because that far out, the PTA, just based on self-report, is often, at least in my experience, not very reliable.
Yeah.
Because what could be, what could be their idea of 2 hours or an hour might have actually been a couple minutes or a minute or so.
Yeah. Yeah.
I don't know if I have a question there or if you have thoughts on that.
No, I think that was a great point. So I worked in the Salt Lake City VA during my residency, and we had a clinic. It was the PTSD and brain injury clinic for people that were in Operation and Enduring Freedom and Operation Iraqi Freedom, so or OEF/OIF. So one of the things that was nice about that is we had a psychologist as a part of the team. We had, a physiatrist or a rehab doc like myself, and then we had a couple therapists. It was a larger system there, so we were better able to try to tease out. We use things like, okay, does the mechanism make sense? The reports that we have, do these kind of make sense? And then we put them through, kind of some physical tests as well as some cognitive tests. A speech therapist was a part of it. And so not everyone has that in the real world. And it's tough. But what I did learn is the two are very similar, and oftentimes they commingle, meaning even someone who has a brain injury will oftentimes have significant post-traumatic stress that's debilitating from the injury or from the accident. And so if we don't address the psychological component to it, we very often don't improve with the physical. So that's kind of what I took from a lot of my time at the VA. And I think you probably noticed some of that in the work that you do, Kelly.
Oh, yeah, absolutely. And I think that you're right, that you have to really, when you don't have good medical records or information about post-traumatic amnesia, it's important to get their self-report and their thoughts, but also looking at other factors, like you said, the mechanism and other things that might be influencing it. So thank you.
Yeah, no problem. Okay, I'm going to move on to part 2, because I think honestly that's the more interesting part for people, given the kind of population where I'm talking to right now, or talking with. So understanding cognitive deficits, understanding spasticity, and chronic pain from brain injury. So post-brain injury symptoms, you'll see a lot of these. So in the left category, you'll see acute symptoms, and you'll see some notes next to it. And in the right category, you'll see prolonged symptoms if these continue. So as you'll notice in the acute concussion or the brain injury, you are going to have 90% of people are going to have headaches. So that's pretty darn common. It's constant, often despite meds. Sometimes we use meds. Oftentimes I don't use a lot of meds to try to prevent headaches in the first week or two, because a lot of times they'll resolve if we work on getting sleep. When headaches become, prolonged, they can cause fatigue. Loud noises can trigger them. Overstimulation can trigger them. So that's kind of that issue. So with the initial injury, sometimes people are really, really tired and might sleep 10, 12 hours, or, sometimes even more. They can't stay awake. They tire easily. Normally that'll improve. When it doesn't, sometimes generalized fatigue will occur. And that's when we look at, okay, is there depression that's contributing to this? Or is this what we call neurofatigue? And in that case, sometimes we use medications to try to help with that. Some of them are antidepressants like SNRI medications or selective norepinephrine reuptake inhibitors like Cymbalta, Effexor, or sometimes we even will use things like Ritalin and Provigil. But normally I don't jump to the heavy hitter neurostimulants like Ritalin and Provigil early, because again, I'd rather try to not use scheduled substances as much as possible with people because of the addictive nature of a lot of these. So sleep disturbance, we talk too much, too little. Issues falling asleep, staying asleep. The reason this happens is in the back of the brain, there's this little gland called the pineal gland that kind of sits in this little opening. And when you get an injury, it kind of rattles back and forth. And that can cause some, basically it doesn't function normally after that. So your sleep-wake cycle can be off and it can be difficult. So sometimes things like melatonin can help. Mood lability, so easily irritated or you tear up easily. If it continues, irritability, depression, something called pseudobulbar affect, where there's a mismatch of emotions or there's an overexpression of emotions that are preventing you from functioning normally. Give an example. Say someone where just a normal commercial comes on the TV and they just start tearing up and choking and they can't, they're just so overcome by it and that they can't even talk about it and it's affecting them. My dad had this with Parkinson's disease, so it's not just exclusive to brain injury. And it can be debilitating because people can't talk on the phone because the second you hit some emotional quality, they choke up and they can't do it. So there's stuff that we can do to help with that. Medications, as well as even some stuff that's over the counter. So nausea, appetite loss, well, this olfactory nerve, the nerve that goes to your nose, sits right in between this thing called the cribriform plate. For those who can't see my fingers, they're kind of crossed. This nerve dives through there. And when you get an injury, it kind of rattles like that. When that happens, you can get damage. So it's very common for people to not have food taste good or to get nauseated when they smell food. And that's something that sometimes we have to overcome. We have to use spice. We have to do some other things. So attention, concentration. Again, we talked a little bit about overstimulation, and sometimes people do really well until they go back to work or school, and then you realize, oh man, they're having some issues. And so that's why it's really important to follow up with that person after they've returned to work, 2 weeks or 3 weeks or a month, and make sure that stuff's going to catch it early before it becomes a habit. Because what will sometimes happen is people that have this issue with the attention and concentration deficits after brain injury or concussion, they will be in a job, they'll do well for a period of time, then all of a sudden, it didn't work well, move on to another job. They're in it for a period of time, move on to another job. So you see this pattern, and it's really difficult. And once that pattern's been established, it's hard to break. So slow processing, we call it brain fog, memory impairment, that sort of thing. So symptom management. Okay, so some tricks. So for headaches, caffeine can actually help. So stress management therapies, preventative abortive medications. We talked a little bit about the somnolence, fatigue. We've talked a lot about all this stuff actually, so I won't dwell on it. It's available for you on the presentation. Oh, so the balance ataxia, we didn't talk much about that. So therapists are hugely instrumental in this, and vision therapy is often very instrumental. So a lot of times people will get headaches. Well, guess what? If our eyes aren't tracking normally, they can create headaches. So a lot of times I'll initially have occupational therapy, see people and make sure that we're doing okay. Sometimes if someone's really severely affected, we'll go straight to the optometrist or ophthalmologist and have them evaluated, and sometimes do some visual training. There's prisms that can sometimes help align eyes and if you've got blind spots, make up for those. There's a lot of things that can be done to help out with that. So this is spasticity. You'll see in this individual's leg, basically you're pulling on it and it's rigid. It's kind of thick. Spasticity is velocity dependent, meaning that if we move it faster, it'll lock up. If we move it slowly, we don't typically have the issues. So that's kind of what it's. Spasticity occurs from a malfunction in either the brain or the spinal cord, and it can manifest in different kind of different presentations. So for sake of time, I'll kind of go through what this question says. It says, which one has spasticity? And the answer is actually all of them. If you look, you can form these contractures at the wrist. You can get this individual, and on letter B, you'll see his foot is angled in. We call that a planovarus. You can see that as well in D. And C, you can kind of see some of the distortions of the face and the lower body. That's spasticity or tone. So what happens is, basically you can get this injury to the brain or the spinal cord, and you can get positive features or you can get negative features. The positive features are those that we can visibly see. So spasticity, if someone's trying to move and they're really rigid, they're kind of walking robotically and their legs are swinging around, that's spasticity, that's hyperreflexia. I can go ahead and move their ankle and that ankle continues to beat. That's called clonus. So that's a positive feature. A negative feature is the stuff you don't necessarily see until you put it to the test. That's the weakness. That's, okay, they can do it once, but they can't do it 5 times. That's the sensory deficits that are off. So both of these things combine and create the muscle pathology after brain injury, and that can create these functional limitations. And so that's a lot of times what the therapists are doing is trying to either facilitate movement patterns to help someone accomplish a task better, or trying to abolish bad movement patterns. And so therapists could do whole talks on this. There's all sorts of ways to do it, and they're very good at it. So we really need to rely on, I rely on a lot of the therapists for help in this regard. So measuring spasticity, there's 2 different ways. The most common way I would say is this thing called the modified Ashworth scale. There's also this Tardo scale, which measures 3 different points. So as slow as possible, you drop the limb, you drop it with gravity, and then as fast as possible, you push it down and you kind of see what happens and they rate it. Very few people use the Tardo scale. Some people still use a goniometer. I cannot pronounce that, goniometer. Basically, they measure the angle at which the spasticity kicks in. A lot of times, this is the therapist that will do this, and that can be helpful because they can use that for tracking, right? Because their spasticity's kicking in at 45 degrees when we started. Now it's up to 60 degrees before it kicks in, and it's like awesome, great, So the modified Ashworth scale, which is what I normally use in clinic, consists of grade 0 to 4 with a 1+ in between. Basically, 0 is no increased tone. 1 is there's a slight increased tone with a catch and release. So basically, the tone is a little more rigid and then catches and it releases. 1+ is the tone and then catch with the minimal resistance throughout the range of less than half the range of motion. 2 is greater than half the range of motion. 3 is it's difficult to move the limb. And 4 is, they're stuck in flexion or extension. And sometimes if they stay stuck like that, it turns into a contraction. So that's what we try to avoid. And that's why we do these therapies and Botox and other things to help. So there's different treatments for spasticity. Chemodenervation is basically treatment with a medication that acts at the muscle nerve junction. That's called Botox. So I do that in clinic. There's also ones that act at the nerves. So for sensory nerves alone, you can use neurolytic medications. These are like alcohol based and you can inject them. The problem is if you have any motor component in it, or if you don't get the nerve component completely, with your injection, you can create a lot of pain or cause weakness. So that was used a lot more commonly, say 10 years ago. Neurolytics are used a lot less now. There's also oral medications which can help. Those act at the brain and the spinal cord. You've probably heard of a lot of them. Gabapentin, baclofen. This is actually where cannabis works, is at the brain. And then there's intrathecal therapies. So what this means is a person has a pump that looks kind of like a hockey puck. It's stuck in their abdomen, and they've got a catheter or a cord that goes around to the back, and it goes into their spinal cord or the thecal area, and they put a medication in there to help act at the brain and the spinal cord. This causes, when you do this, you can use a lot less of the medication to get more of an effect. So the idea is you can use 1/100th or 1,000th the amount of baclofen in a baclofen pump, and so you get less of the physical side effects, the constipation, and some of those other things you get from when you crank up the oral medications really high, and you get a stronger effect. So that's the idea of a baclofen pump. Cannabis, this has obviously been the hot topic in the last few years here in Michigan. In Europe, this is actually, there's some drugs that have been out there for a while. The results are actually kind of impressive. Now, I'm not advocating everyone go out there and start smoking marijuana, because I don't think that's right for a lot of reasons, but it can help with some of the spasticity and the tone when CBD substances are used. And so that's one of the things that sometimes when we really get one of those persons that is having a hard time and we've tried all these other things, I say, you know what? Have you been to such and such a place and talked to somebody about maybe trying a CBD oil, seeing if that helps? So they use this study called the numerical rating scale, which basically measured, this was done in Germany. Basically, patients had to be treated with at least 2 oral antispasticity medications. Most of them were on baclofen, and then some were on these other medications. And then they used this medication called Sativex, which is a CBD-based drop that you would put in your mouth. And they defined a clinically relevant responder, meaning greater than 30% improvement in their reporting of their spasticity symptoms. And the crazy thing is, so that was a 0 to 10 scale, the lower number being better. So the crazy thing is a lot of these people improved a ton. So the score for this numerical rating scale went from a 7 down to almost like a 6.7 down to almost a 3 at 3 months, and 41% of the people that were classified as responders. 55% of the population felt they had benefit from it and actually continued the use of the medication after the study was over. The main reason for stopping was efficacy for about half of them. Some people did get some of the cognitive side effects from it, even though it wasn't supposed to have the THC in it. And then there are other reasons that people, had, including dizziness and fatigue. So I guess the moral of the story on this is that, it can help with tone. The CBD can, but again, there's other effects that can cause issues. Obviously, if someone is, cognitively affected from marijuana and they're trying to walk around, their balance is going to be horrible. So you really need to take things with a, grain of salt. The moderation is the key if you're using the CBD oil, really doing it in a stepwise fashion. So, there's a change, and then also talking to your provider about it, because some providers still have this idea that, okay, you either use something with CBD and, or THC, and you use that, or you use pain meds, or you use that, or use something else, but you don't use both in conjunction. And so that can be difficult, and you don't want to get discharged from your clinic because you were trying something just to help your tone or spasticity. So chronic pain. So I use this drawing a lot in my clinic. And I basically just draw it out on a sheet of paper, and I basically say, okay, this is how a brain should be, right? You've got your family in a quadrant, you've got yourself, you've got your work, you've got other things. And what happens when we have chronic pain is we develop these habits, and these habits have a tendency to create, this expansive, larger piece of the pie. And when that occurs, it's hard to focus on the other important things in life. And this is why counseling and psychology can be so important to help get pain in the appropriate box where it should be. Most people have an element of pain, but does that pain run your life? And figuring out if it is running your life now, how to get it to be a smaller piece of that pie so that you can gain some of those desirable things back. So I kind of talk about that. So again, the pathway for pain, you get hit, you've got these slow fibers and you've got these fast fibers that the fast fibers tell you to move your hand back right away so you don't get burned by the stove. The slow fibers are more of the long acting, the kind of, oh man, that's really achy kind of pain thing, the stuff that comes later. The reflexive pain is that, that's the fast back and forth kind of thing. It oftentimes doesn't even go to the brain. It just goes to spinal cord and then boom, back, you move. The other stuff goes to the brain. It has these different areas in the brain stem, and then it kind of goes through this pathway to the thalamus, where there's a relay system for it saying, oh, this is where it's going on. No, you shouldn't be scared about this pain. Or yeah, guess what? That thing you're seeing there is a bear. You got to run, so you understand what's going on. So brain injury and chronic pain, up to 50% of people do have chronic pain disorders following a brain injury. It's a pretty high number. It's not made up, it's real. The most common pain is neck and back pain. Headaches or nerve pain are also very common. What's important is, and sometimes the spasticity can cause pain. What's important is to understand the reason for the pain, and then to treat the reason. And then also, so questions you can ask. Okay, is the pain sharp and burning? Is it dull and achy? Trying to figure out if it's this neuropathic pain or the nerve pain. That's the sharp burning, numbness, paresthesias, or is it inflammatory pain? Are they having like an osteoarthritis response? Are they having rheumatoid arthritis? Do they have an autoimmune issue? Is the pain coming because guess what? Your limb's contracted and you can't move it. It's really painful, and all the fluid and the nutrients that need to come through the elbow are getting stuck there because you don't have any blood flow back. Is it phantom pain? Is it pain that you lost a limb and your toes are crossed, but guess what? You don't have any toes anymore, so they can't be crossed, but your limb keeps thinking that. Again, that you treat very much similar to the nerve pain, muscle aches, and then there's this regionalized pain where oftentimes you can get pain to a nerve or a muscle, and when that muscle is not moved, it can develop and actually have these physical changes go on. It can increase initially when warmth and get really hot. The skin can start getting glossy, it can lose the hair, and then eventually it kind of goes to a chronic phase. And so what we want to try to do when someone has this regionalized pain is treat it early and really treat it aggressively. We'll talk a little bit about that in a second. So again, neuropathic pain, pinched nerve versus upper motor neuron issue. You use physical therapy for mobility, desensitization techniques for hyperalgesia or like increased pain response. There's meds we can use. There's for inflammatory pain. Energy conservation techniques. We need to avoid flares. Guess what? If you're doing all this stuff with your wrists, when you've got this, arthritis at your wrist, maybe we should have you in a brace and try to decrease the movement at the wrist, that kind of stuff. Ice and heat. So the way I tell people is for osteoarthritis, is think of it like a car. If you got a car in cold weather, you want to heat it up before you move it. So your body, the same thing. If you're going to go out and have a hard day outside, go ahead and try to, use some heat and warm up the area that is going to hurt. And then after you're done doing it, cool it down with some ice. So same thing, think of it like a car. Anti-inflammatories can help. Sometimes rheumatology referral or a modulating drug to help out with autoimmune issues. And then tone, spasticity, we talked about anti-spasticity meds and some of those things. So the phantom pain, again, there's really cool things out there that people can do with therapies. One of my favorite is mirror therapy. So basically, if you have pain with a limb or a limb that isn't working right, you go ahead and you create a box for that limb, and you kind of put that limb in the box, and then you've got a mirror on the side of the box, and then you sit here and you look at the mirror, and you move your good hand or your good leg and do the things that are hard to do. And what'll happen is this other side your brain will be seeing that other side is doing it, and it can kind of help reestablish those patterns. It can help decrease the pain. I have people that have limb loss do this, and I say, okay, you're feeling your toes crossed, but your toes aren't there. What you need to do is you need to get a mirror, put it in between your legs, and I want you to have, your spouse scratch your toes on the good foot. And they're like, what? I'm like, yeah, scratch your toes on the good foot and scratch them and do that. And they're like, oh man, it helps so much. What you're doing is you're tricking your brain. So that kind of stuff can be helpful, and it doesn't involve any meds, which is nice. Musculoskeletal, again, strengthening for the back, that kind of stuff, the neck. So in general, when we're using musculoskeletal pain treatment, we use the least dangerous medication at the lowest dose possible. So for example, tramadol or Tylenol-3 prior to things like Norco or Percocet if you can. Sometimes you can't, and we've got to go higher, and in that case we do. But again, these medications do have side effects, and they have long-term addictive potential, so we got to be cautious. Regionalized pain, organic versus non-organic pain. So the big thing with this is this fear of movement. It seems to underlie most disorders. So patients are scared that if they move, they're going to hurt themselves more. And so sometimes they need to be told this mantra, yeah, it's going to hurt to move. It's been stuck in that position for a while, but guess what? It's not going to make it worse. It's not going to harm you more. You need to move it, and that's how you're going to improve it. And so I like to use that mantra, and feel free to steal that if you need to. It's going to hurt to move, but it's not going to harm you. And so, again, PT can be helpful, medications. There's some procedures that can be helpful early on. Something's called a sympathetic block. That would be done under imaging. They basically block the nerve ganglion that's upstream and has the nerve that's distally or towards the limb that involved. So you kind of block the numbness and the center of the pain, so to speak. And then some important things to remember. Each brain injury affects the person differently. So different mechanisms cause this. The location of the injury is different in each person. The severity of the injury is different, and the repetitive nature of it. So did you have more than one? And the recovery of the injury is different. So there are other neurologic disorders that can develop from brain injury, and they're very real. Chronic traumatic encephalopathy, Parkinson's, dementia. Those sort of things are more common after you've had a brain injury. Typically, it takes years to have those come about. As we get older, they do come sooner. So if someone's in their late 80s and they have a brain injury, it's not uncommon for 4 or 5 years down the road for them to be developing worsening dementia. If a person is in their 40s and has a brain injury, typically it's a good 20 or 30 years before they start developing the major kind of issues related to memory loss and things like that if they develop it. And not all people develop it, but you are at increased risk for it. So there's also social consequences associated with brain injury, and I really hope this sticks. I try to say this in each of my talks. There's this phrase here that says, loneliness does not come from being alone, but from being surrounded by people who can't understand you. It's a deep feeling of isolation that comes when you realize that even the person standing right next to you is unreachable. So unfortunately, this is the way a lot of people feel. And this creates this depression. And it's tough. it can make someone perform worse. And then we say, what's wrong with the therapy? What do they need to be on another medication? And they may just need interaction. I mean, this is, unfortunately, with our current COVID stuff that's going on, this is one of the biggest issues I've seen with people is they're having this. And so counseling is huge, understanding that we need to treat the depression and the social isolationism. You know, this whole idea of, basically socially isolating, I don't really like that term. We use it, but what we really need to do is we need to, instead of isolating for COVID, we need to stay in touch, but we need to use different means of doing it. We need to use this kind of platform. We need to create these groups, of people that can talk back and forth over this. Yeah, it's not as good as being in person, but guess what? It's a whole lot better than being on your own. And so that's something that I want people to remember. Another thing I want people to remember is the difference of inclusion versus integration versus isolation. So inclusion implies acceptance. It means asking the person with the brain injury to be a part of the whole. You're including them in. This is validating. This says, hey, I like you who you are, and I want you to be, hang out with me. I want you to be a part of stuff. Integration, this is different. We use this term all the time, and we don't really use it right. But basically, we're asking the person to change to fit in with the environment. And that doesn't validate someone. That doesn't say, hey, I like you who you are. This says, you know what, I need you to stop doing this so that, the other people don't have issues with it. Instead of saying, you know what, hey, come over here. Let's work on this together. So integration, I don't like that term as much. Isolation is, again, we talked about what happens when basically someone notices that they can't completely fit in normally and they become isolated, and we don't want that to happen. So again, diagnosing a brain injury, there's different grading scales. Even a concussion is a mild traumatic brain injury. Imaging is not the best predictor. Length of post-traumatic amnesia is the single best predictor. Brain injury disorders and treatment, there's both physical and cognitive deficits. Oftentimes, the physical ones will improve first, which can be difficult and create kind of a walking wounded scenario. Spasticity is common, and there's multiple ways to treat it. Chronic pain is common, and the best way to treat chronic pain is address the root cause of the problem. And narcotics are not first-line treatment for any cause of pain, but they may be valuable adjunctive treatments in the correct setting. So I've got just kind of literature and resources on here, and I'm happy to take any questions you guys have or try to answer. Or listen to statements like Kelly's earlier. I thought her statement was great about the types of patients she sees at the VA. So. Any questions, guys, or did I lull everyone to sleep? I can't see. Hope not. Uh-oh. Hopefully I didn't lull people to sleep.
Not us.
We're here.
All right.
No,
all right, good. I was like, man, have I just been talking for 45 straight minutes and no one was on?
Dr. Cole, this is Devin. I'm the speech pathologist at outpatient rehab at Munson. And I just wanted to say that I have a lot of patients right now that you have answered so many and just helped to guide me in the right direction when I'm just like thinking about the psychological component and all of these pain management issues. And it was just so helpful. And thank you so much.
Oh, thank you. Yeah, no, I'm happy to talk to you guys anytime as well. And I mean, if at some point you want me to come over and talk to the group over there, I can do that as well. So I'm cool with that. So. Anyone else have any other thoughts or different experiences?
Hey, Dr. Cole, this is Ashley, speech therapist. Thanks for your talk. Thanks. I appreciate hearing you always. I had a quick question with regards to pain management. We have a mutual client. We were at a team meeting and the chiropractor seemed to have been adamantly against baclofen pumps. I think he was more of a, naturopath, and it opened up a discussion about long-term dependency, etc. He also
Mhm.
doesn't specialize in brain injury either, let alone severe brain injury.
Okay.
So I was wondering if you had any of the recent research or any recent developments on the long-term effects of it that you've seen.
Yeah, I mean, a lot like whether you develop a dependence and have to keep increasing the medication, that kind of stuff. Is that what you mean?
Yeah, not just that, but even he was kind of just talking more about, yeah, like the neurodependency on it and the side effects that come with that. So it's kind
Yeah.
of the battle between comfort versus, comfort and pain relief versus the side effects of, having to eventually wean them down and off. It was just an interesting insight that I hadn't really thought about.
Yeah. Yeah. Off the top of my head, I don't have any research on that. But what I have noticed, yeah, people over time, if they've got tone, they do have to go up on the pump. But the great thing about the pump is that you can go up, just easily adjusted. It's a magnet that I can stick onto someone and kind of increase the amount of medication as needed without going in and doing any major procedures. And even though it seems like a large number, say 2,000 micrograms, think about it in terms of what I'm giving you orally. So I'm giving, somebody orally 120 milligrams. That's a 1,000th difference. And so the overall effects on the body actually seem to be a little less than if I'm using high dose of oral medicine to try to help out. In terms of should everyone have a baclofen pump? No. There's a lot of people that don't need them. But for the person who's really developing that contracture or has spasticity in more than one limb or lots of areas where we're not able to treat it effectively with the therapies and the Botox and all this other stuff, that's when you really say, can we maybe try a pump and see? And the nice thing about it is you can do a baclofen pump trial where basically they don't put the pump in yet, but what they do is they just say like a woman that has an epidural, I would send the patient in, I would have therapy work with you before. I would have them kind of do their assessments. Then the interventional person would stick an epidural of baclofen in, and then we'd assess you at 4 hours after, and typically 1 hour, and then 4 hours after, and see, do we get improvement in the tone? And if we do, it's highly likely that the person's going to respond well. If we don't, then we're faced with, well, do we want to go through with this procedure because it's an implanted pump, right? Less than 5% of pumps will have issues. Typically, the issues don't revolve around the pump itself. It's normally the catheter. And the catheter comes detached, say if someone had a seizure and they banged things really hard and or things come unclicked, or the catheter tip moves a little bit. And so overall the complications, even though it is a neurosurgical procedure, most of the neurosurgeons typically say this is one of the easier procedures, and it's pretty safe in comparison to some of the other surgeries people go through. So
Sure, I would say most of my clients that have had it have seen such great benefit. So I appreciate your perspective on it. Thank you, Dr. Cole.
Yeah, no problem. And I'll look and see if I can find anything about physical dependence and stuff like that. But people are scared of what they don't know a lot of times. And yeah, it's a foreign object that's implanted in your body. Guess what? So is a joint replacement. And
right.
so
I invited this chiropractor
that's become
in question.
accepted.
Right. I just want to know, just for my own
Yeah.
purposes, so that I have a better way of kind of standing up for the client and the procedure in future to say, here's the research behind it. Here's what I know. So I appreciate that. Thank you.
Yeah, I'll look and see if I can find something for you, Ashley, and send it over on email to you. So
yeah, thanks. I appreciate it.
Anyone else have questions or thoughts?
I do. This is Rena.
Okay. Hey, Rena.
My question for you is about the corpus callosum and injuries to the corpus callosum. I know that its development is, early in life. It gives you, what I'm thinking of is like that feeling of connection with others? And if you have damage to the corpus callosum, does it really depend on how severe? Will that interfere with like emotional connection, connection with others? Like how does that repair? Does it repair itself?
It's like other areas of the brain, right? One of the things that I tell people is that the brain is beautiful in that it's redundant, meaning there's more than one area to accomplish a task. And so oftentimes when one area is damaged, we can use others to try to, take over the damaged area. And that's the whole idea of therapy. With the corpus callosum, it's difficult because that is in charge of what our left mind, our right mind. We use this whole idea. It's the thing that divides us right down the center of the brain. And you can get, if you get damage there, you can get people that don't recognize really the opposite. They get like an alien hand type syndrome where, they don't recognize what their other hand is doing. And they, can be doing other stuff and their hand just kind of does its own thing. It's, in terms of repair, it's the same as the other areas of the brain. But it like you said, it can be more severe, especially different than the peripheral issues, because again, you're kind of knocking out a relay center, our ability to go from one brain to the other and make decisions back and forth.
Right.
Does that make sense?
It does. And I always think about that when I'm doing treatment because, at least with AAT or some positional release things, I'm always looking at from left to right, right to left, and trying to treat like it's not easy to reach, but a left arm and a right leg at the same time or something like that, just to, again, always thinking about that connection of left and right brain.
Yeah, I absolutely think that using the AAT technique, and especially in injuries like this, would be useful and beneficial because, again, what we're trying to do is reestablish those connections between the two sides of the brain. That's what the corpus callosum is. And for people that can't really see it, so it's this little piece right here, the circular, I don't know if you can see my thing, but this is the corpus callosum, and that's that's what we're talking about here, is this thing. And it sits right in this dead center and helps relay stuff left to right and tell us what to do. So
it's like an electrical bridge, right?
Yep. So it comes from the information kind of comes from the periphery, and it comes from the brainstem, and it kind of goes through here, and it goes to one side or it goes to the other. And so if you've kind of knocked out the middleman, sometimes the messages don't go to where they need to go. So.
Cool. All right. Thank you so much.
Yeah, happy to help. Any other questions? This virtual presentation is kind of fun. It's harder for you guys to boo me all at once.
Thank you so much, Nicole. That was awesome.
Yeah.
Nice job.
Yeah, I'm happy to help. And I apologize that I haven't taken as prominent of a role in kind of doing stuff with the Brain Injury Network. I really respect everything that's going on. I love the organization. It's just been right now kind of a personal decision. I've limited a lot of the stuff that I do outside of work just because of trying to help out with family and stuff. But I love what this network is, and I'm happy to support it whenever. So anytime you guys have a need for something, I'm happy to help. So.
Well, thank you. We appreciate your support immensely.
Yeah, no
Everybody was
problem.
looking forward to this presentation. Everyone's been talking about it for the last week or so. So thank you so much.
Well, cool. Well, thanks for inviting me to do it, and feel free to put this on the website or do what you need to do with it. I'm happy to have it there or to share it. I think I sent it to Steve.
Yep.
I'm happy if someone asks you or needs it, just go ahead and have my permission to send it out to them. There's nothing that's proprietary or anything on it. So
all right. Thanks, Dr. Cole.
And this has been recorded,
yeah,
so everybody knows, so that we can it will be put on the website. So if anybody wants to spread the word or watch this later on at a different date to kind of recap everything, it will be available for everybody. So
cool.
Awesome.
Sounds good.
I think the
Thank
guy
you, guys.
confirmed this is probably our biggest turnout for any meeting or session.
Yes, you are right, Sandy.
I've never seen that many of us get together.
We broke a record
Well,
tonight.
Well, this is what we need to do, right? It's, you know, this whole social isolation, it shouldn't be social isolation. It should be, you know, virtual, you know, coming together. And so I'm happy to do this kind of thing whenever. So,
All right.
Cool. All right. Take care, guys.
All right.
Thanks so much. It's
Thanks
awesome.
so much, everybody. It was great to see your faces tonight, and look forward to more information. And remember, we're looking for a secretary, and we're looking for people for the education and outreach committees.
And then if you want CBIS points, fill out the form on the website on the main page, and I'll send you a certificate.
Perfect.
Cool.
Any questions
care, guys.
or any ending information that anyone would like to share? All right.
All right.
We'll call her good
Thanks
with
for
that.
putting this
Thank you so
together.
much, everybody. Thank you, Dr. Cole, for tonight. And we will catch you real soon. Signing off.
Good night.
All right.
Thank you.